So this is our 34th session of Adda, and this Saturday we have a very distinguished guest amongst ourselves, a very illuminated and illustrious alumni member. So Dr. Biswaroop has agreed to be our speaker today. So he is currently an additional professor of pediatric neurology at AIMS New Delhi, an alumnus of Maulana Azad Medical College and AIMS New Delhi. Biswaroop has more than 100 research publications in indexed medical journals and around 30 chapters in leading textbooks. Currently, he has been teaching at AIMS Delhi since 2014 in the curriculum of MBBS, MD, DM, and PhD at AIMS New Delhi. And apart from it, he is also passionate about pediatric neurology advocacy in our country and has numerous research grants to his name. So today he will be talking on his experience as a medical researcher in India and how to balance between being a clinician, medical researcher, and an academician in India. So I think without much further ado, I think I would invite Biswaroop to take the stage and start the presentation today.
Thank you, Satyam, for that wonderful introduction. I hope I'm audible.
Yes, yes.
Yeah. So, good evening, everyone. So I'm really happy that few of you could actually, join on a busy Saturday. And sometimes, Saturday is also the day when we relax. So even then, some of you have joined on a late afternoon on a Saturday. So what I'm going to do over next, 1 hour or so, I'm going to talk about how I landed up in what I am today, and it was not something which was pre-planned or not something which was actually, I had thought about it. It just happened with lots of things happening by chance and, just because of destiny. So I'll be talking about, I'm a doctor at AIMS New Delhi. So how, being a doctor at AIMS New Delhi, we have to, fill up all these gaps. Like we have to work as a clinician, we have to do medical research, and we also have to, be academician. We have to train the budding doctors of the next generation. So just a second. Yeah. Is the screen moving, Satyam?
Yes, it's moving.
Okay, so the outline of the presentation would be, I'll start with a brief overview of the journey so far. So what all I did so far in life to the current position that I am in. And then I will be talking about the components of the current, professional realm, which includes clinical work, academics, research, and advocacy. And I will end the talk with concluding remarks. So to begin with, I did my class 10th from RKMV Vidyapit Deoghar in 1996. And then I did my 11th and 12th in DPS RK Puram. I was there in 96 to 98. And then I joined Maulana Azad Medical College as an MBBS student in New Delhi. 1998, I joined. 2003, I finished my MBBS and internship. Then 2004 to 7, I did my MD Pediatrics from Maulana Azad Medical College. And then from 2007 to 2009, I did my senior residency in pediatrics in Maulana Azad Medical College. So why MBBS? I would start with that part because, a lot of it is destiny and a lot of it is in my life. I initially had different plans, but I landed up doing something else. But eventually what I do is something that I enjoy exceedingly. So I initially had plans to become an engineer, but I had bio as a subject as well in class 11th and 12th. So when I joined my 11th and 12th in Delhi, at that point of time, I was not allowed to join coaching outside the hostel. So eventually I thought that, okay, I'll drop the plan of being an engineer, and I started preparing for MBBS by second half of class 11. And soon I realized, that things soon started falling into place. I started preparing well. I started appearing for some tests, and I saw that this is something in which my calling was there. And so I started preparing. And then I joined Maulana Azad Medical College, as I told you. So I was there from 1998 to 2002, 2003, I did my internship. And then in 2004, I qualified the Delhi postgraduate entrance. And then I joined Maulana Azad Medical College only as MD in pediatrics. Now, the second question is, why did I join MD pediatrics? So what made me, join MD pediatrics? So I would say, I had excellent exposure in pediatrics during MBBS at Maulana Azad Medical College, New Delhi. The department was very good. The faculty was very good. The clinical exposure was very good. The teaching was very good. And I automatically got attracted to the subject. And somehow, as many of us would believe, that you get some sort of satisfaction when you treat children. So this was another reason why I joined pediatrics. And one very important aspect is, I mean, particularly people who belong to the branch, and otherwise also you would realize that it's a challenging branch because a lot depends on observation. The patient is most probably not going to communicate with you, may not be even cooperate with you. Your communication will be mainly with parents, and you have to ask the right questions and show a lot of patience. So it was a challenging branch, and overall all these factors were there. And most importantly, because the department at Maulana Azad was very good, I joined MD Pediatrics in 1998. Then I finished, as I said, that, from 2004 to 7, I did my MD in pediatrics. Then 2007 to 9, I did my senior residency in pediatrics in Maulana Azad. Then eventually I thought that, I should move ahead in life. And I did my DM in pediatric neurology from AIIMS New Delhi. That I did from 2009 to 2012. So post that, from 2012 to 2014, I was working as a senior research associate at AIIMS New Delhi. And then 2014, I got absorbed there as an assistant professor, followed by an associate professor at AIIMS New Delhi from 2014 to 21. And since 2021, I was an additional professor. I'm working as an additional professor at AIIMS New Delhi. So, again, the question was, why DM in pediatric neurology? Trust me, in 1996, when I left Vidyapit, I never thought I'll become a pediatric neurologist. When in 1998, I joined MBBS, I never thought I'm going to become a pediatric neurologist. Even in 2004, when I joined pediatrics, I never thought, I'm eventually going to pursue neurology, because most of us would know that, who are from the field particularly, that neurology is something which most of us are scared of when we are an undergraduate. So what worked, for me was that I had an excellent mentor for my thesis guide during MD. And this topic was actually a pediatric neurology topic. So during MD only, I got a very good exposure in pediatric neurology while doing my thesis. And if you think of neurology as a branch, even till date, a lot depends on clinical skills, even after performing the best of investigations. So a lot of it actually depends on the clinician, how you interpret what you are seeing in the patient, what you are seeing in the investigations, and then you decide that, okay, fine, this is what the diagnosis is, and then I'm going to treat. One of the other reasons, which was a major reason at that point of time, because when I was joining my DM in pediatric neurology, I never thought that, I'll be eventually working at AIIMS. I thought I'll become a pediatric neurologist and eventually practice somewhere. And a major chunk of pediatric cases which presents to the healthcare are actually neurological problems. So this prompted me to, think of picking up this as a branch. And then there are diverse diseases in pediatric neurology. So that was one of the main reasons why I thought that, fine, so this is one branch which I should pursue. So then why I eventually landed up at AIIMS. So I never joined DM, as I told you already, thinking that I will eventually work in AIIMS. So when I joined at AIIMS New Delhi, the faculty that I had at the Department of Pediatrics, it was, an eye-opener for me. They were all global stalwarts. They were people about whom I have read in textbooks. You look at any particular topic in pediatrics and you'll find their names everywhere. And so just watching them work was an inspiration in itself. So when I joined AIIMS and I started seeing these people work, it actually worked as a huge inspiration for me. Now, the other thing that actually motivated me to work at AIIMS was the environment at AIIMS New Delhi. They allow you to think out of the box, and you have a freedom to work within ethical and moral bounds. That means you have to follow medical ethics, you have to follow all the moral values, but at the same time, you're allowed to think out of the box and work. I always had a love for teaching, so that worked in that favor that, okay, fine, I should, pursue at my work at AIIMS New Delhi. When I was working at AIIMS as a DM in pediatric neurology, I developed passion for research, as I told you, looking at all the faculty in the Department of Pediatrics. And all these were done with one common final goal, that is, do good for the patient. So eventually, when I had finished my DM, I was almost 90-95% sure that this is what I want to do. I want to work at AIMS as a faculty in AIMS. But then at that point of time, there were no faculty openings at that time, and it's usually a very tedious process, because when you appear for the interview at AIMS, it's a very competitive environment, and you actually have to develop a good, research as well as an academic resume, and then only you are actually eligible for the interview. So then I appeared for the interview in 2014. I was fortunate enough, I got absorbed, and then I have started working. So now what I will do is, as I had already mentioned, that there are actually 4 realms of working at AIMS. So we have clinical responsibilities, we have academic responsibilities, then we have the opportunity to excel in medical research, and then eventually, somehow, because of the place you work in and the opportunities you get, you end up doing a little bit of, or maybe some amount of advocacy in that particular field. So what are the kind of clinical responsibilities that currently I have? So we have an inpatient clinical service in which you have sick neurology patients up to the age of 14 years. We have a ward as well as a high dependency unit. And usually I round every day for 2 months over a 6-month period. So over a 6-month period, you may have around 2 months of rounding these inpatient clinical services. In addition to that, we have twice a week morning outpatients. These outpatients are like, OPD services where you sit in the OPD and you see patients. Then we have specialty clinics in the afternoon. You have lots of, subspecialties within neurology. So we see those patients in the afternoon 4 times a week. And we have around 1 to 2 on-call duties per month for the general pediatrics emergency services. And I have around 10 on-call duties for neurology patients per month. So I don't have to be at the floor, but I have to be on call 24 hours on those days. So when I say pediatric neurology, I just wanted to, give an overview of what disorders we actually end up seeing. So it's a very wide spectrum. Most of us are aware that epilepsy, then we have infections, then we have disorders which primarily happen because of altered immunity. Then we have disorders of the nerve and muscle. Then we have sleep-related disorders. Then we have degenerative disorders, behavioral disorders, and we do have stroke in children as well. So as I already said, there is a very diverse population that we get to see. And so pediatric neurology has a wide spectrum of patients. So what are the laboratory services that we provide? So we have, what we call electrophysiology lab, in which we have video EEG or electroencephalogram, which is particularly, here you can see that there are multiple electrodes that are attached to a child, and we record the brain activity of those who have fits. And then we have even ambulatory EEGs for those who are sick and on life support. And then we also study muscles and nerves, and these are all for various kinds of pediatric neurological disorders. So my role at this point of time, these are primarily done by technicians and our trainee residents, but is to supervise their work, look at the reports, and help in day-to-day maintenance as part of the core faculty team. Now, this is something which I wanted to talk separately. So pediatric polysomnography services. So these are actually sleep. This is our sleep lab, which is also part of the electrophysiology lab. So we have around, so this is something which I was part of the core team, which operationalized and started the pediatric polysomnography services at AIMS. And now we have research going on. We have clinical services being provided through this lab. So now moving from clinical responsibilities to academic responsibilities. So what kind of academic responsibilities do we have at this point of time? So we have undergraduate or MBBS lectures. We have outpatient and inpatient postings of undergraduates. So while we are seeing patients in the OPD and in the ward, we have undergraduates who are posted who have to be trained. Then we also have MD pediatrics teaching and training. So we have morning classes. They have their thesis. So I have been chief guide for 4 MD pediatric students till now. I've been co-guide for many. So then we have DM pediatric neurology teaching, that is post MD pediatrics. They would be doing DM in pediatric neurology. So they have twice weekly classes. I've been chief guide for 6 of them, and again, co-guide for quite a few. And then we have the PhD curriculum, in which we have basic science postgraduates after finishing their post-graduation would appear at the AIMS postgraduate PhD entrance, get qualified. So at this point of time, I'm currently working as a co-guide. It is primarily because of the workload. when we already have a DM program running, it becomes a bit difficult to be a chief guide for a PhD curriculum. So it's easier for us being co-guides. Then we have nursing curriculum where we deliver lectures. Apart from that, this is what I do at AIMS. We have the Association of Child Neurology at India. So I'm one of the core committee members of the education vertical. As part of the endeavor of this, we conduct, twice monthly symposia, workshops, lectures, these kind of journal reviews, this kind of activities, which is for all practicing pediatric neurologists in India and adjoining countries in the Southeast Asia. Apart from that, I have been fortunate to be faculty for various national and international symposia, workshops, and conferences. So, when you work when you contribute as an academician, you get these opportunities, and particularly working at AIMS. So this is the standard textbook of pediatrics, which is, followed by, I think, residents, undergraduates, not just in India, in neighboring countries and abroad as well. It's a very easy to read textbook. So I have a chapter in that. So I've contributed in the developmental and behavioral disorders in children. Then we have a book by a postgraduate textbook of pediatrics, which goes by that name. That's also quite a popular book, which is edited by Dr. Piyush Gupta, and it has a lot of volumes. So I've been fortunate enough to have two chapters in this. One is on mitochondrial disorders, the other is on acute flaccid paralysis. So these are, core neurological disorders. Then again, this is a neonatology book in which I have a chapter on a particular disorder in neonatology. Then this is an immune-mediated disorder. You must have heard about multiple sclerosis in adults. It is a disorder of altered immunity. So the pediatric multiple sclerosis. So I have a chapter on a standard textbook of clinical practice of multiple sclerosis. And this is something very interesting. So this was something that came out, JP came out last year. So their endeavor was, having lectures which are video recorded. So the person who is actually the author would be delivering the lecture. So this is me along with one of my residents. So we have talked about how do we actually examine development, that is mental and physical development in a 6 month to 2-year-old. So this is a video chapter. This is something new that they've started last year. So these are some of the salient chapters that I've been fortunate enough to be part of. And, this primarily because of the place where I work and all other associated activities. So these are the prominent chapters. Now moving on to, this is one part in which I think I'll be, spending some time. So how do we develop research interest and profile? Always remember, when you work at AIMS, this is not the primary, what should I say, work that is expected of you. So the primary work is definitely patient care and clinical responsibilities. And then it is academic responsibilities, because you have trainees from, various MBBS curriculum, MD curriculum, DM curriculum, PhD curriculum, nursing curriculum. So you have to teach them. They are the future of the country, and they are the best minds who clear these sentences and come. But even then, if you have to excel as a doctor at AIMS, this is something which you have to find time for and excel in yourself. So, I mean, how do you develop research interest and profile? So I would, say, as a clinician, when we do research, how do we look at the research topics? And then I will talk about some of the prominent researchers. I will try to keep it as simple as possible so that even people who are not from the medical background are able to understand what I'm trying to talk. So we try to pick up a disease which is widely prevalent, can have devastating consequences, but provides windows of opportunity to improve the outcome. So as you see, there is something written in front, convulsive status epilepticus. We'll be talking about it and how, this has helped me grow in my research in pediatric neurology. I'll be able to talk about that. Then the second part is, when we look at a disease, we should not be just looking at the disease through a tunnel vision. We should have a holistic approach. And how does it help? It helps by, leading to improvement in overall quality of life. So this is sleep disorders. Now, what happens, sleep is something which we all take for granted. We think that, we all go to sleep every day in the night. We get up in the morning. Sometimes we sleep well, sometimes we don't sleep well. And we just feel that, that's okay. That's part and parcel of life. So apart from being primary diseases in sleep disorders, these are also comorbidities in various other disorders. Then you have conditions which you diagnose early, you can treat them completely. But if you leave them untreated, they would lead to long-term physical and mental handicap and disability. So very important to identify them early. So this is also one area where we would, we like to work. Then again, work with common disorders which are prevalent and which you can treat very easily, because these are the ones who are actually going to benefit by seeing you. And then you have disorders which are uncommon, which are rare, and then you can develop, simple diagnostic strategies to diagnose these conditions. So as you can see, some of these terms for people who are not from the medical background may be a bit foreign at this point of time, but don't worry. As we move forward, these terms will become clearer and easier. So as I said, convulsive status epilepticus. So it actually forms the first heading. That is, you pick up a disease which is widely prevalent, can have devastating consequences, but it provides you windows of opportunity to improve the outcome. So what is it? So it is actually continuous fits that happens, or brief fits which happens, and the child doesn't regain consciousness in between. So anything that lasts for more than 5 minutes would eventually continue for 30 minutes if you don't give the right medications. So it is one of the commonest childhood emergencies. As you can see, the annual incidence is quite high, almost leading up to 17, 1 lakh pediatric population. And why I said it has devastating consequences, after an episode, up to 30 to 50% can have mental and physical handicap. So you have to actually look for windows of opportunity so that you can actually act and improve the outcome. So as I said, if you look at this slide, so any seizure lasting for 5 minutes would continue for 30 minutes. So once a seizure starts, the family is definitely going to take more than 5 minutes for reaching the hospital. So that is the reason why pre-hospital management is very important. So you prevent the progression of this entity called convulsive status, you prevent damage to the heart and lungs, you prevent damage to the brain, and then, there are protracted episodes. That is, if you have prolonged episodes, they may be associated with death, they may be associated with long-term handicaps. So you have a group of drugs which are called benzodiazepines. So they are given intravenously. Now, what happens if a child is convulsing or seizing or having fits? At times, it may be difficult to give an injection. So this is where we got an idea. This is one of the earliest studies which happened from India. So we started looking for alternate routes by through which we can administer this drug. So this is the study that I'm talking about. So this was actually my MD pediatrics thesis. So we looked at this drug and we actually administered it through the buccal route, through the mouth. And we compared it with an IV drug by what we call a randomized control trial, which is usually the highest form of any intervention study. And we could see that this actually works quite well. So this was published in Brain and Development. It's one of the better journals in pediatric neurology. So this was actually the study which motivated me later to pursue pediatric neurology in future. Now this study has had a good effect after that. It is now part of most of the recommendations that come out globally for pre-hospital management. It is part of most of the articles which publish on this topic. They always refer to this article. Now, the other topic on the same thing, that is in convulsive status epilepticus, that I looked at was we tried to formulate a score. So this score, actually a patient presenting to the hospital, so you can actually apply that score and see how the outcome is going to be. And accordingly, you can decide about how to go about managing this patient. So again, this has published in Epilepsia, which is also a very established journal. Now, this has actually been identified as a breakthrough research paper by the European Medical Society, and they have actually asked to pursue further, and they want more written material from my side on this particular topic. So again, these two particular researchers, in convulsive status epilepticus, a condition which can have devastating consequences, but the window of opportunity that it provides, if you treat appropriately, then you can improve the outcome. As a part of this, now what has happened is I have got this grant now from the Department of Health Research in India, which a grant of around slightly more than 50 lakhs, in which they're allowing me to develop models based on biomarkers, clinical features, and then we can predict the severity and outcome of this condition. So how does it help? Just a second. So how does it help? It helps by, I'm applying both conventional statistics and machine learning. So machine learning is something which has come up in a big way. So I have collaborated with the Indraprasth Institute of Information Technology at Delhi. So once we come out with these models, we'll be able to stratify risk in this particular disease. We can prioritize therapy-related decisions. We can prognosticate, and we can look at newer treatment for this particular disease. We're also planning to develop a mobile application from these models, which will help in, which will give a model how to manage this condition so that there is uniformity across centers in the country. So it's not that you have to come to AIMS to get treated, or a leading hospital like Lady Harding to get treated. You can go to a health center and they can also treat you. So this is one of the ideas why we are planning to develop this mobile application. And once we develop these algorithms and models using conventional statistics and machine learning, we'll be able to generalize across various healthcare settings. As I said, not just the tertiary care, at secondary as well as primary healthcare settings. And then, these data sets can further help in, developing these models, fine-tuning these models, looking at, policy decisions, treatment-related decisions in various settings in future. Now, as we move on to this topic, this is something that I told about, that this is actually sleep problems. So as I said, when we approach a disorder, it should not be tunnel. Tunnel means that we just look at the disease and send the child home. But actually that particular disorder, the child may be having sleep problems. So when we do a holistic approach, it leads to improvement in quality of life. So the development of sleep parallels physical, behavioral, and neurological development with key reciprocity. So it means that sleep is very important for our physical development, neurological development, behavioral development. And poor sleep is actually known to cause, poor intellect, behavioral issues. And studies have shown that up to 30% toddlers, preschool children, 37% school-age children, and 25% of adolescents may have sleep problems. So these are some common disorders that most of us have heard names of. So they may have comorbid sleep disorders. So this is the American Academy of Pediatrics, which says that, children should be screened for snoring during outpatient visits, which provides an opportunity to counsel parents regarding the importance of sleep. So actually snoring is not a good sign. It's actually a sign of bad sleep. And so one should screen for them. So what was the idea behind, this particular topic? So where is the gap? So what happens in children? In children, it is impaired behavior during daytime and poor performance in studies, which are commoner manifestations of sleep disorders. Rather than, they would say that I'm feeling sleepy because I didn't sleep well at night. They would rather be saying that I have, the children will be having behavioral issues, may have academic underperformance. And many times we may actually think, why is the child not performing well? Why is the child behaving in a hyperactive way? And the cause could be just, impaired night sleep. And then we have these children and adolescents. They are dependent on their caregivers, that is parents and us, to maintain sleep hygiene and seek intervention and support whenever required. So children and adolescents may not be able to say that, we have sleep problems, please help us. So it is important for we, the doctors, the healthcare providers, and the parents, guardians, caregivers, to identify these problems and seek healthcare support whenever it is required. So whatever evidence was there, we felt that there was lack of awareness at the level of caregivers as healthcare providers. And so we thought that why don't we go ahead with few studies? So what did we do? So what was the idea? The idea was that, at the school, at the level of counselors, at the level of psychologists, they all should be empowered to identify these problems in children and adolescents. So we can develop some simple questionnaires, which will be helpful in screening children for sleep disorders. Because as you saw, I showed you in the initial slides that, sleep is actually evaluated by polysomnography. So it's a very tedious procedure. In government setup, okay, fine, you don't have to pay. But in the private setup, it's an expensive procedure. The child has to stay in the night. Many times the child is uncomfortable, and what you record may not be actually reflective of how the child's sleep is. So we thought, why not develop some questionnaires, which can actually help screen them for sleep problems and help solve this problem to a large extent. So we came out, with this various studies. So I'll start with the top one. So this is, the child and an adolescent sleep evaluation questionnaire, which has got published in one of the leading sleep journals, which is the Journal of Sleep Research. And what we did was we developed and validated a screening instrument, a questionnaire, a very simple questionnaire, which you can apply for within 5 minutes. We developed it in both English as well as Hindi. So it's a bilingual questionnaire. And we studied these in a school and as well as, children who came to the hospital. So almost 750 children, this questionnaire was applied, and then we developed this questionnaire. And this is actually the first of its kind in the world, which is based on the latest sleep classification. So till now, globally, there is no sleep questionnaire available, which is based on the latest. This is International Classification of Sleep Disorders. So our center, we could come out with this questionnaire. Uh, then as a part of this study only, we found something very interesting. So when we applied this questionnaire and we looked at prevalence of sleep problems, what was striking was that, the children and adolescents who were within 2 to 18 years and had academic impairment. So academic impairment, we thought, we graded them according to their grade in exams. And we found that actually the ones who have sleep problems are academically more impaired, or the ones who had academic impairment had significantly more sleep problems. So you can understand that this is something which most of us won't even, it's not just about, common man, it's also about doctors. Even doctors are not that aware about sleep and its implications. And again, I'll say that what we did, so as part of an MD thesis, what we did, we looked at the awareness both for the parents and the healthcare providers. And what was surprising, again, it was in the same population, but this was applied in the children, and this was by the parents, caregivers, and we studied a group of MBBS interns and nurses. And what we saw was something very interesting again, that there was hardly any difference between the awareness of somebody who is a non-medical person and a medical and nursing graduate. So we understood that it's not just at the level of society, it's also at the level of healthcare providers that we are not that aware about sleep. So we want to take this study forward further. And currently, we are also studying one more aspect, as most of you would be aware that there are children who don't achieve bladder control by 5 years. Beyond 5 years also, they would pass urine at the night. So we are trying to study the biology of this nocturnal enuresis in children. This is part of an MD thesis in which I am a chief guide. So again, look at simple problems and try to find out simple solutions for these problems. So as clinician, our studies are primarily focused at looking at simple solutions, easy solutions, affordable solutions for larger problems. So what is the way forward from these studies? So many of us may think, okay, fine, you did this study, so what? So it's actually, so this tool that we developed in the current study, the first one, which I said was the questionnaire, which helped us in screening for sleep problems, the first of its kind. So it was done in a good sample size. So there were 750 children on which it was done. Importantly, it was done in both English as well as native language, Hindi. And the outcome of the questionnaire was evaluated with the clinical and polysomnographic evaluation. So it actually, we could compare that what we were getting out of the question, was it matching with clinical and PSG evaluation, and it gave a good number. And it, as I said, the current classification, it covers most of the disorders. It also covers other medical comorbidities, psychological comorbidities, how we sleep. It covers all those questions. And actually, it's a questionnaire which you can apply within 5 minutes. And there is a key available with the questionnaire which tells us whether sleep problem is present or absent. And in fact, when we looked at individual types of sleep disorders, we found encouraging results even in them. So it would be worthwhile that we, further validate it, various demographic settings, ethnic settings, clinical settings. So what we are currently planning is at the level of maybe, primary healthcare professionals or MBBS doctors, we allow them to apply this questionnaire, come with their conclusion, and then we match it with our evaluation, and we see whether this can be used as a screening tool in the community for sleep problems, because the prevalence is very high. The expertise is less. Polysomnography is a very tedious procedure. So why not just a 5-minute questionnaire to evaluate problems of sleep? Okay. The other one in which I said that we looked at, caregivers and healthcare providers, and we actually found that they were almost comparable. So what we came out was that the medical curriculum should have more reinforcement about sleep, because it is a neglected area, as most of us who are doctors here would realize that we didn't study much about sleep in our MBBS curriculum. And then they can be developed into self-assessment tools based on that questionnaire, so which we are again planning to develop into a mobile application. Now, moving on to the third group of disorders. So again, there would be early diagnosis of treatable conditions. So again, it's the condition which you can treat easily, you diagnose them early, because if you leave them untreated, it can lead to mental disabilities, physical disabilities. So again, this is an entity. So I have tried to keep it simple so that all of us, are on the same page. So immunity helps us fight infections. This we all are aware. So what happens just after an infection? So the body's immunity may attack body's own proteins, which are similar to external proteins. So what I mean is, suppose there is a bacteria So the body has actually, the immunity has started working against that bacteria. But you may have your own proteins, which may be similar to that bacterial proteins, and your own immunity may start working against you. So what is interesting here is that brain proteins are particularly susceptible. So you have some prototype disorders in which you have a myelin, a brain protein, you call them demyelination disorders. Then you have a type of encephalitis in which, if we think of encephalitis, we actually think that this is actually infection of the brain. But you may have encephalitis caused by excessive immunity, which attacks our own receptors, our own cells. And what is the unique fact that these conditions get treated by medications which suppress immunity. So you need to identify them early. So commonly we use steroids. Now, these are relatively rare entities, and mostly, whatever data is available in the medical fraternity is from the Western population. So a bit again on these disorders. So these disorders can be one-time events, or they can even occur again and again. So differentiating them very important, because the ones which are going to occur again, you have to identify them and start treatment on a long-term basis. On the other hand, the ones which are one-time events, you treat them and you don't then continue the treatment, because steroids, you all know, are harmful. So some relevant scientific facts. So we have proteins called HLA in the body, which are like our gatekeepers of initial response by the body's immune system. So these proteins could be ethnicity specific. And so what happens? We have a hyperactive immune system. It would attack through various inflammatory mediators. So basically, you have an immunity, which usually works against infections, but it can also act against your own body. And this is what we are trying to study in the neurological disorders. So again, what we did, we collected our data over 10 years, and we found that, whatever data is available from the Western world and from adult population cannot be extrapolated to children. And so we need to study this further, because we found newer findings from this study. And again, in this particular encephalitis, it's a rare form of encephalitis. We were the first center from the country which came out with this data. So based on this, I currently have an ongoing AIMS intramural grant around 10 lakhs over 2 years, where we're trying to differentiate the ones which would happen once compared to the ones which would happen again and again. And it is based on some biomarkers. And as I said, the gatekeeper protein HLA. So it is just, how we look at disorders. We try to find simple solutions, and then we try to see whether we can have a funded study which can help us understand the disease better, more so in our own population, because what we see in the West may not apply to us. What we see in the adults may not apply to children. Again, we are looking at another MD thesis in which I am a chief guide. So we are looking at, when a child presents, can we actually predict what is going to happen? It is going to stay one time, or it is going to occur again and again. And we are also trying to see what is the outcome, so that, we can manage their disability better. So what is the expected outcome from these studies? Okay, fine, so what would happen if I do this study? So again, for the first time, this is happening from a non-Caucasian, that is a non-Western population. Again, this would help differentiating the ones that are going to happen once from the ones which are going to happen again and again. And we are going to monitor treatment response and disease progression. And this would also help in developing predictive models, because eventually we are going to apply AI in this as well. And then we would be looking at the current diagnostic criteria, because there's a dynamic and primarily extrapolated from adults. Do we have newer criteria for children? And again, you can quantify the disability that these disorders can cause and plan appropriate rehabilitation. Now, this condition is, again, a very common condition. Many of you would have heard about it. It is a disease in which it's the commonest cause of fits in our part of the world, and also in South America. It infects the brain and causes a small lump or swelling. It is usually caused by this tapeworm, and it is actually a waterborne disease which is spread through food. So it is insists that the food which has this causes this disease. At 6 months, it gets calcified or resolved, and then up to 75% would get calcified. And once it becomes, a focus of calcium in the brain, it causes recurrent fits, and the child may need recurrent medications, prolonged medications, which is because there is an inflammation in the brain. So again, we're trying to study a condition which, if left untreated, can lead to disabilities, but if we pick up early, we can treat well. So I'm just trying to show in this slide, this is something which, because I'm working at a place which provides you with all these opportunities. So this is a specific form of MRI in which you can look at the blood supply of the brain. And this is one child. This is where the lump is. And you see here, you are seeing it completely blue, which means there is no blood supply here. But you look at here, this is another child, the lump is here, and you see very good blood supply here. So this one, because of lack of blood supply, this area is having some disease, and this one is causing seizures, whereas this one is not. So we came to understand that, okay, fine. So there may be some form of inflammation, which is leading to lack of blood supply, and then this may be the cause for seizures. So based on the findings of this study, so this was again an intramural research grant from AIMS, which 10 lakhs over 2 years. And so, I could study this. And then in these two studies, these are, my DM students' thesis. One, we are trying to see if we give 2 doses of steroids, how the disease is going to behave in the long run. And we are also looking at another study where we are seeing that if we identify a group of these children in whom if we give drugs for less duration, can they be given for less duration and still they are fine? Because at the end of the day, when we give these medications, they may have side effects. So targeting inflammation differently to see the outcome, best duration of anti-seizure medication, that is medication which controls fits to avoid unnecessary usage and side effects. And currently the best duration to give these medications is not known. So again, we identify a disease which is prevalent, which causes fits, and then we try to understand, that does it, what is the underlying pathogenesis, and then we try to use that knowledge in our clinical practice and see whether it makes a difference. Now, this is again another type of fit which responds to drugs. So again, we work with common disorders which are amenable to intervention. That means work with disorders which if you treat, they're going to get fine. So again, a disorder which has high prevalence, around 50% of them respond to these medications, which we call anti-seizure medications, the ones which are given for fits. The ones who respond, they have relatively preserved IQ, but they still continue to have academic problems and learning difficulties. So we thought, why not study the biology of this? And then we try to understand what we can do about these children. So they are more prone to develop psychiatric disorders compared to those who have overall lower IQ because they have higher IQ. They understand the disease, they understand their problem, and as a result, they develop behavioral issues, psychiatric issues. And these problems can persist in a good proportion over a period of time. So again, this is, again, the place that I work in provides me with this opportunity. So these are functional MRI. So what a functional MRI? These are nothing like you're doing something and your MRI gets recorded at that time. So we saw that the ones who had problems in intelligence, the ones who had problem in behavior, their areas of the brain were differentially activated than the ones who were not having. So we understood that, okay, fine. So this is how the ones who have problem, their brain work. So by seeing the areas that are getting activated in the brain, training of the child can be planned. So currently we have a study under consideration by a funding agency where we are developing a mobile application and an activity booklet based module to test whether it works or not. So we will first develop this module and then test in these children and see whether it helps them in overcoming their problem with intelligence and behavior. So again, we have a AIMS undergraduate mentorship project, which around the funding is around 2 lakhs. So we get to mentor these undergraduates who are interested in research. And we are again trying to see that when we give these medications, do these medications have effect on intelligence and behavior? So once we have this data, we'll be able to say more confidently whether these medications can cause or not, because many times parents discontinue these medications thinking that the behavioral problems or the problems in intelligence are actually because of drugs, and they end up having more fits and more brain damage. So this is the last area which I chose. So these, when you look at this term, this is a very uncommon disease. So we thought we'll develop simple diagnostic strategies. So what are these? These are dystrophies or degenerative muscle disorders, which are caused by genetic defects in specific proteins. So we do something called muscle biopsy to diagnose this. It requires hospital admission, some amount of surgical expertise and sedation. And the other way to diagnose them is genetic studies, but then it is limited by cost constraints and availability. So this was long back when I was doing my DM. This was my DM thesis. So we thought, why not do a very simple thing like a skin biopsy? Doesn't require admission, doesn't require surgical expertise, doesn't require sedation. You just, like a pen, you put it inside the skin and take it out. It's a very small piece of skin, and that would help in diagnosis. So this actually got published in a journal called Journal of Child Neurology. So I'm just trying to show in a very simplistic way. So this is the skin. So this is a child who doesn't have this disease. So you can see these brown structures, they're taking up the stain. On the other hand, you can see this is the child who have the disease and the brown structures are not taking up the stains. They're very light. So a very simple procedure like a skin biopsy could actually obviate something as complicated as a muscle biopsy, or something which is expensive, limited by availability genetic testing, and we could diagnose a disorder, prognosticate the family, because these are disorders which don't have treatment at this point of time, and we need to identify them early. And lots of studies are going on in terms of treatment, and skin biopsy can be done repeatedly to see whether the treatments are working. So multiple benefits of this study. We looked at similarly another disorder which is even rarer than the disorder I talked about, and again we saw the same findings in skin biopsy, and again another disorder, again same findings. So rare disorders happening in our population, we try to see how we can help them in our resource constraint setting in simplistic way, so that the diagnosis can be made easy. So these are some. So till now the studies that I have talked about are primarily, as principal investigator. So I'm the main, you can say, the primary person who has been funded or got this opportunity to study. And these ones are where I am a co-investigator, in which these are actually psychogenic events. Children are actually play acting seizures or fits, and we looked at them because many of them, up to a good proportion, actually get medications for events that are not fit. So we looked at them. It got published in a good journal called Seizure. Now this is again in status epilepticus, which I talked about, continuous fits. We came out with this protocol for something. We induce coma in these children so that the fits can be stopped. Now this is something very interesting, and this got published in one of the most established and reputed journals, JAMA Pediatrics. So we looked at various forms of diets and whether diet can be helpful in children whose fits are not responding to conventional drugs. So we compared these various diets, and I happen to be one of the co-investigators in this study. As co-investigator, I have not mentioned all. I have part of few of these good studies. So there is an ICMR registry for rare disorders, which has a funding of in excess of 1 crore over 6 years. Then we look at children who have low intelligence, and we try to see their genetic studies. Again, Department of Biotechnology, in excess of 80 lakhs. And this is an interesting thing, which we are trying to see, that in adult population in Delhi, by using some WHO criteria, can we classify disability in them? Because once we quantify disability, we'll be able to help them in a better way. So before moving on to the next part of the talk, I talked about all these things for the simple reason that research is not the primary work that we do at AIM. Our primary work is still clinical, care. Our primary work is still teaching the children. But this is something which most of us who work there, it's our passion. So, we apply for various competitive research grants. So you send a proposal, the proposal then can get rejected or can get accepted. And once it gets accepted, you get this fund, and then you can pursue these studies. So we actually cannot study like basic scientists, like they can study cells and other stuff, and they can, study it for a longer period, because our primary work, our primary mandate is something else. So in between, while doing our clinical work, we come across problems, and then we try to see how, by doing simple things, if we are able to solve these problems, or we are able to make a change in a patient's life. Okay, so now coming on to advocacy. So what does it do? It ensures uniformity. So how we get involved in advocacy? So most importantly, because we are able to work in a lot of disorders, we are able to work in a lot of rare diseases, because we are at AIMS, we are able to see a lot of these patients. So we are able to be part of these treatment guidelines for them, which ensures uniformity of treatment guidelines. So once we have these guidelines, no matter where the child is, the child will be treated equally in across the country. Then in special circumstances, we can provide services. Then we can ensure and help some of these children who suffer from neurological disorders, especially able. So we can help them through advocacy, but to achieve their maximal potential. So some of these, like, currently I'm part of the National Technical Expert Group for developing guidelines for management of, again, some rare neuromuscular disorders. You would be knowing about it because a lot of this crowdfunding, gene therapy, all these things are being talked about these days, because these are very expensive medications. So we are part of the technical expert group, and we are trying to see whether we can help these patients and how useful these medications are. I've been part of the expert team for, looking at various disorders, which includes stroke, which looks at various types of epilepsy, again, status epilepticus, which helps us in, having standard treatment guidelines across the country. I've been part of the expert panel again for developing the sleep module by the Indian Academy of Pediatrics. I was, part of the ICMR national consultation and a Ministry of Health and Family Welfare expert when there was an AES outbreak in Muzaffarpur in 2019. We went there at the peak of the outbreak. We tried to understand what was happening. We looked at the children. We tried to understand what was happening in the locality there. And there was this blame game going on with lychee. And we eventually understood that, lychee is not the actual culprit. The actual culprit is a practice of feeding and the overall malnutrition and the climate along with lychee, which is causing this. And subsequently, we could give them that, guideline as to what they can do. And fortunately, the episodes have come down in subsequent years. Again, this is a disease in children. I've been able to contribute as a part of the National Academic Board. And then, we have been conducting these training programs for healthcare professionals across the country who can identify these disorders and certify these disorders so that these children can avail maximum benefit out of, whatever the government is providing. So I'm also part of the disability board that certifies these children. So if we certify them appropriately and on time, they can achieve maximum potential and they can also avail a lot of benefits from the government. So now I have come to the last slide of my presentation. So what is the way forward? So where am I today and what do I see in future? So the clinical care is still the most important responsibility and will stay as the most important responsibility being a doctor. Academic role is also paramount importance because you get to train these people who want to be future doctors, future specialists, super specialists, nurses. So it's of paramount importance. Now, research is actually born out of these two things. This is not the primary work that we do, but we have to ensure that we do good quality research, which is clinically meaningful, and it promotes patient care and academics. And we should develop this habit of publishing the work in good journals, because if we publish it, then only, people will come to know about it and it will have a better reach within the country and outside as well. So the advocacy opportunities that we land up having are actually just an offshoot of doing this work. Good clinical care, good academic role, and then doing quality research so that they identify that, okay, you are one of the people who can contribute as an advocate in this particular disorder. And I'm at this point of time, I have more than 20 years left at AIMS, so relatively young, and I'll always strive to improve. So a long path stays ahead. One important thing that I want to tell you, as I had told in my initial presentation, that I never thought that, when I did my class 10, that I want to become a doctor. Actually, I was preparing for engineering at this point of time. So this was not my first choice. Eventually, when I came to AIMS for doing my DM in pediatric neurology, I never thought that, I would continue here. My first priority was to, be a more skilled person so that, I can have better job opportunities. But when I look at myself now, what I'm doing, I think this is what I always wanted to do. So maybe, life, it's always doesn't turn out or doesn't, happen the way you plan it. It provides you with surprises, and it's always destiny which ultimately decides what you're going to do in life. So thank you so much for a patient hearing. I know some of it could be a bit, off track because it was hardcore science in between, but I tried to make it as simple as possible, but I'll be happy to take questions. Thank you so much for the patient hearing.
Thank you, Biswaroop, and for a very balanced yet a kind of detailed overview of what you really do and how you contribute to the society and our good health. So the floor is open for the audience to ask questions to Biswaroop.
So, Dada, my question
Yes,
to you.
Satyam, please.
Yeah, I am Rishi from 1997 batch.
Yeah, hi Rishi. Hi.
Hi, Dada. So my question is, how easy or difficult it is to separate your emotions and not get involved when such complicated patients turn in an AIMS? People generally reach AIMS with the last hope that this is where God is and they come there. So I somehow want to hear it from you how easy or difficult that part is.
See, it is overwhelming when you start as a postgraduate, because in MBBS, you're more like a student, it's more like a college. You go to college every day, you enjoy your college life, you come back, and then these things start setting in once, you you start your post-graduation, that is once you start doing your MD. So initially it's a bit overwhelming because more so it involves children. You see the family, which is, getting carried away. They feel, how can this happen to their children and things like that. And then what happens eventually over a period of time, once you finish your MD, you go through your, rest of the course and everything in life, you get used to it and you are actually able to see it in a more objective and scientific way. Because one thing that is very important is all these disorders, and when you actually look at some niche diseases, it is very important to counsel the parents properly. So unless and until, so what we call it is empathy. So you have to feel what they're feeling, but at the same time, you should not be carried away by emotions, so that you are able to, counsel them in the proper way. So this is what we usually follow. And it usually comes with time, it doesn't happen, as you are absolutely right. In the initial years, it's quite overwhelming. Yeah.
Right, Dada. Thanks.
Any other questions?
I have one query. We see doctors in like multidisciplinary hospitals like AIMS or some other government hospitals do some bit of research, maybe not as much as still not as much as somebody would do in a hospital in US. But why is it that none of the private hospitals actually carry out much research in India? So at least I can see in Patna. So in Patna, hardly any doctor in a private, even a multi-specialty hospital would be interested in research. So why is this gap between a government setup and a private setup?
I would say this is, very good question. So what actually happens is, the mandate is different. When you look at the private sector, they have a lot of thing to cater to. Most importantly, the work that is happening there is primarily driven by how many patients are coming, how many patients you're able to treat properly and send home. So this is actually the mandate. When you are in the private sector, your priorities are different. So what happens, at a place like AIMS, or for that matter, leading, medical colleges in the country, like I would say, because I'm talking about pediatrics, I would say Lady Harding Medical College, or for that matter, say Maulana Azad Medical College. What happens, that these places, we join these places primarily because this is one of our passion. And unless and until you have passion for good research, unless and until it's a priority in your life, you actually won't do good research. The other thing is, when you look at these funding agencies, because look at all these opportunities, as I said, intramural research grant, 10 lakh for 2 years, 10 lakh for 2 years, then again 2 lakh for undergraduate mentorship research. So these things, these opportunities are provided at AIMS New Delhi. I don't even think that most of the other medical colleges would be providing. This happens only at AIMS and maybe the other AIMS that have come up now. So you need to have that opportunity. You need to have that environment where you are actually doing quality research. So there are private hospitals, like leading private hospitals, where they have DNBs going on. So I won't name it because it's not a good thing to do. But then these hospitals, they actually do research because an academic program is happening. So academic program and research, they go hand in hand, because when you do quality research, it's of use, as I said, if it gets published in a good journal. And this happens only when you have academics going hand in hand. And in all these premier government institutes, be it AIMS New Delhi, PGI Chandigarh, SGPGI Lucknow, then you have JIPMER Pondicherry, then you have place like, CMC Vellore. So all these places, you have good academics going on. So people who are academically driven, who, have passionate about research, they actually end up getting more funds because this is their priority. So they write proposals which in competitive settings, get more approved. And somehow the reputation also works, that, this place, people will be doing research in a more meaningful way. So more chances of getting funded. And also remember that many of these fundings, when they come from international agencies, they look at, helping the underprivileged, the ones who are not, don't have access to, say, a private setup. So they end up also, this is also one mindset which works. So more funding actually comes to the government institutes for research. So this is one of the main reasons why this happens.
Regarding funding, so is the funding at say AIMS New Delhi, is it adequate? Or even at top levels,
Yeah.
you guys feel that
So what happens,
No, maybe I
you're absolutely right. So what happens,
yes.
so when you look at those, so as I said, what happens, we look at conditions and then we decide about research in what I would say in small pockets. So what happens if we want to do a study which can happen without funding, we usually would do it through a thesis, because thesis usually don't get funding, particularly for MD, DM, all these people. If we want to do a study which will do with some amount of funding, we try to do it through intramural grants, which aims has a corpus and gives to its doctors. But then we have big agencies like, say, ICMR, that is Indian Council of Medical Research. Then we have Department of Health Research. Then we have Department of Biotechnology. Then we have Department of Science and Technology. Then we have international agencies like, say, Inclin Foundation. Then we have DBT Wellcome Trust. Then we have WHO. So all these agencies then provides with funding opportunities, but these are again competitive opportunities. You have to give your proposal. The proposal may get accepted, may not get accepted, purely based on merit, and then you get an opportunity to work. So this is how it usually works. So we divide our research work into research which may not need funding, research which needs a little bit of funding, and then research which needs a lot of funding, and we accordingly apply to various agencies.
Thanks, Biswaroop. And I think Anindo from your batch has a question now.
Okay. Hi, Anindo.
Hi, Biswaroop. So good to see you here. So I have in two parts, a comment and a question, and I'll try and keep both brief. So first of all, as your batchmate, behalf of all of us, we are incredibly proud of your journey and what you've achieved. And all of us having seen you grow as a person and professionally as well. And I think you'll agree, this whole balancing act, one key aspect that you're always so modest about is your singing, which you managed to, sort of keep throughout. And you like the Kishore Kumar and Palash Sen rolled into one in AIMS. So it's lovely to see that also, whether it's at the RKM events or otherwise. So I think that's the comment part. Please keep it going. Our best wishes. And my question, of course, I think I must also add that it was a lovely presentation. You explained a lot of complex concepts very lucidly, and I'm sure you must be one of the favorite professors in AIMS. Sort of. So goes without saying. And so my question is essentially on the advocacy part of your presentation. So on that, very specifically, most of the time the child spends is obviously in environments that you don't control. You can only counsel, like you said. So whether it's at home or whether it's at school. So and one thing that I've known, and even let's say Ritesh that he lives abroad, in our travel and stay outside our country, we've seen that for people with recurring health conditions, which could be more like disabilities, there are a lot of enabling factors in those environments to help them live a normal life or as close to possible. So, but in India, you don't see any of that. I understand we have our problems. So to put it very simply, my question is, in your advocacy role, what are the 2-3 things, simple things that you advise, say schools or parents, to make changes in the environment so that they can live as close to a normal life as possible? Say an epilepsy patient, for example.
So this is again, something very interesting. So, what happens when we label a child as disabled? So again, this is something very objective. So they have to cross a certain percentage of disability to be actually labeled as disabled. And then the benefits and everything comes. So one of the things which has come up in a big way now is inclusive education. So which means every child has the right to education and going to any school that the child wants. And what the school provides is that the school provides with special educators who are there to, guide these children. Now, what happens is that once we label the child, CBSE has this, CBSE or other boards, they have these provisions where each child, according to the disability he or she has, will be benefited. Like, for example, say somebody has a learning disability, has difficulty in writing. So once we train them and then they reach a certain level, they may be given extra time during exams. Or for that matter, they may, if they have not reached that level, but they are able to understand concepts, they're able to speak it, they can have a writer along with them. So, these things are coming up more so in bigger cities where you have special educators and all these people in various schools. Then you have counselors who look after all these things. But as you said, what we do is we have started training healthcare professionals across the country so that, they are able to identify these children at most of the places. They're able to certify, and then, these children can avail these benefits. The other important thing is, what we encourage a lot is parent support groups. So what happens when parents of these children who have similarly affected kids, so they interact with each other, so that social barrier, it's broken. So suppose if it's a parent interaction group and all the children have a similar problem, the parents don't feel that social barrier when they meet socially. So these are some of the things that we do, say parent support groups, ensure that, CBSE provisions are taken care of. The school has special educators wherever the child is going. So, and then we have this open school, then we have integrated school, which are again, slightly easier curriculums to help these children. And currently the focus has also shifted to, more of vocational training, encouraging, any special skill the child has, rather than, just seeing to it that whether they're able to pursue conventional curriculum. So maybe some of these things. A very simple thing, like I'll tell you, most of the hospitals, you can see even airports, or, when you board a flight, you will see a ramp these days rather than stairs. So these are again, disability friendly, what I would say, steps, small steps. So these things may be very common in the West, but yes, our country is picking up slowly. Definitely.
Thanks. In fact, there was this recent incident in Ranchi where a child was not allowed to board.
Absolutely. Yeah.
It comes to mind.
Absolutely.
Yeah.
Absolutely.
Thank you. Vishal, there's a chatter going on in our batches WhatsApp group that everybody wants to listen to a song from you. So maybe
I don't know whether
couple
others
of
want to
lines.
do that.
Couple of lines just to.
For that, we have to take permission from the organizers, because I'm not
Biswaroop, you have the permission. This is Adda Baji,
Acha. Okay. So I'll sing this, Kailash Khair number. I'm very fond of this song recently. And in fact, one of our batchmates only, Avinash, only suggested me last time that, next time, whenever you sing, you should sing this song. So I'll sing few lines from this song. It is Saiya by Kailash Khair. हीरे मोती मैं ना चाहूं, मैं तो चाहूं संगम तेरा, मैं तो तेरी सैया, तू है मेरा सैया, सैया, तू जो छू ले प्यार से आराम से मर जाऊं, आजा चंदा बाह में तुझ में ही गुम हो जाऊं, मैं तेरे नाम पे कर जाऊं सैया, सैया. Thank you.
It's very rare to see such an all-rounder, Dada. Wonderful to have you.
Thank you, Rishi. Because, this actually helps me. You also asked me, how do I handle the stress? So music actually helps to de-stress to a very significant extent. So when you have a stressful life, something or the other, performing arts, it helps you de-stress. Like Anindo, had a wonderful session on, I remember, on art. So performing arts, fine arts actually helps in de-stressing to a significant extent, particularly if you have a busy professional life and things like that. So this actually helps.
Right, Dada. We look forward to the culture program. We are knowing that you are the captain of that event. So we look forward to that.
One of the person who is trying to see things. Yes, not the captain.
Yeah, okay. So we look forward to it. Thank you.
Thank you.
Any more questions from the audience before we?
Dr. Biswaroop.
Yes, sir.
Yeah,
yes,
I am Dr. Sanjay Sinha of 1975 batch.
Hi, Dada. Hi.
So, yeah. So it was great to hear such a nice presentation from your side. So I do not have any questions. I just only want to thank you. And
thank you so much, Dada. Thank you. The words mean a lot. Thank you.
And then this rare talent means you really sing so well that my wife came and asked me if means some expert is singing or what. Then I told that
Thank you so
now he's a doctor in AIMS in pediatric department, and he's singing very well. Thanks very much.
Thank you so much. Thank you, Dada. Thank you.
So here we are, Biswaroop. Thanks to you. I think we started about the opportunity for you to come and share your work with us about 3 or 4 months back. And thanks for accepting the invitation and making it happen.
Thanks for the opportunity, Dada. It's a wonderful opportunity because we always talk in professional settings, but talking with your childhood friends, childhood seniors, dadas and brothers. I mean, it's the icing on the cake. I mean, this is a great opportunity.
One final question, Biswaroop.
Yeah, Samir. Yeah.
Do you love being a doctor in India, or you would wish to work somewhere else?
No. I'm very sure I want to work in India. I want to work in India.
Do you love working in fields or in ends?
In field or at AIMS?
Yeah.
I would prefer working at AIMS because, as I told you, academics and research are an important passion. So along with clinical work, I'll get to do these things at AIMS in the best way in the country. So that is the reason I would prefer working at AIMS. So I'm being very frank.
Okay. Thank you. All the best.
Thank you.
Thank
And
you,
you
Samir.
being a pediatrician, you understand this quite well.
Yeah. I am at work right now, so I know whatever you told me. It's very practical.
Thank you.
Okay.
Okay, so continuing where I left, thanks to all the audience who came and joined in. And this shows how we alumni across the batches and across geography really enjoy different topics, especially coming from our alumni. So just to give you a background, which may help and strengthen our community of alumni, Adda is supposed to be an informal session where you can share anything. It can be from your professional background or something to do with the pit. If you are a good singer, where it gives an opportunity for everyone to learn and enjoy. So if anyone in your batch is interested in participating in this Adda, they are most welcome. We have very good volunteers among Satyam and Vikas,
Absolutely.
or you can contact me. We can send the form, and I think Biswaroop, from your batch, we have quite a good contribution, including Anindo, who spoke about art, which was very different from usual things which we do. And the next Adda is also going to be very useful, is from one of our dadas from 1969 batch, Dr. Gautam Sengupta. He is a linguist, and he is one of the pioneers who has translated Carnatic songs into Hindi, and there are few videos, some South very good singers have sung it. So hopefully, along with Biswaroop, we will see many of you there, and the details would be coming soon. Not to stop here, as you know, we have our 100-year centenary reunion coming on 25th to 27th November, and Biswaroop, as someone Rishi shared, is heading the cultural activity. So you will in your inboxes and chats, you will find requests from Biswaroop or the committee to join or contribute through your talent. It can be singing, it can be any instrument which you can play, or some play which you can do as a group or a class or a batch. So we are also looking forward to have Biswaroop's guidance on that. If I have missed anything, or if someone asks,
I will just
and
like to add one thing, Dada.
Mhm.
We were fortunate to have 10 students from Vidyapit also today who had joined after hearing that one of our illustrious alumnus who is in AIMS is talking. So few of them are still in the talk. Some of them had to go because they are at home and traveling. So it was great for Biswaroop also to talk to them, because it's a great inspiration when we are in Vidyapit talking to some of our alumnus like Biswaroop. Thanks again.
One request, Ritesh da.
Yes, please.
Just have a session for doctors for investment purpose. How to make savings and investment.
Acha. Okay. We had few sessions, I think 2 sessions on investment, but of course, while you have mentioned it, we have one of our seniors from 1993 batch. He is basically a fund manager. He manages a mutual fund based in Mumbai, and we have been in talks with him to uh, come and in layman's language share his experience.
Yeah.
Not too fancy.
Language should be very, simple. Like we doctors can also understand that.
Yes. So that's his mandate, to make investment not only for professionals, but teach the people just after someone enters their professional life how to start investing, saving, etc. So in fact, our calendar is full for next 2 years. So that means every weekend we have someone from our Vidyapit alumni coming and speaking on various topics. So because of many people coming forward, we used to have one adda in a month. Now we are having 2 addas a month. So these new, as you said, new dadas coming on investment, and anyone from your batch we will accommodate, and it will be to have a good session across different batches and different subjects. So anything more, or should we finish this session with a vote of thanks to Dr. Biswaroop once more? Okay, Biswaroop, thanks a lot, and hoping to see you, your batchmate, other dadas and juniors come and contribute. And we are really looking forward to the cultural event. We have great faith in you. Thank you very much.
Thank you so much for the opportunity. Thank you so much. Thank you.
I will stop the recording, and if someone wants to